All right, so a recent study on testosterone therapy with men who are at high risk for cardiovascular disease has caused some talk in the medical community because of the surprising and confusing results. Can you tell us a little bit more about this study?
Sure. Uh, the study was a sub-study of a study called Traverse, and that study looked at cardiovascular events in older men with cardiovascular disease or high risk of cardiovascular disease. But the sub-study examined the rate of fracture in those same group of people. Um, it was about a little over 5,000 participants. The average amount of time on treatment was a little over 3 years. Uh, and what the shocking part, the part that's caused interest and controversy is it actually, unlike what was anticipated, showed an increased number of fractures in the treatment group. Now, the difference wasn't statistically significant, so it'd be easy to dismiss it. And I think people probably would think that's what I'm going to do. But in point of fact, I want to suggest that the problem is real. That is, I do believe that there is an association between testosterone treatment potentially and increased fractures in older men, particularly. But I don't think it's related to a negative effect of testosterone on bone health, which is what people have been suggesting from this. On the other hand, I think it has to do with other effects of testosterone that are very important to understand and the implications of that relationship through which it could, in fact, increase fracture risk are extremely important to understand when it comes to both how we approach the patient and how we design future studies.
Okay. So these results are very interesting. Can you get into this in a little bit more detail? Why exactly are the results surprising?
Well, in the past, there's been numerous studies looking at testosterone with bone health, and that stems largely because we know in women, estrogen supports bone health. Um, and so it seemed intuitive that that might be the case. And in fact, multiple studies have shown that testosterone improves certain aspects of bone health, bone density, bone architecture, bone strength, for example. On the other hand, to still make it a little more confusing, there have been other studies that link testosterone treatment with an increased risk of musculoskeletal injury, like Achilles or bicep tendon rupture or rotator cuff tear.
So, how do you account for this association that testosterone replacement therapy increases musculoskeletal injuries that they showed in the study? In other words, more specifically, why do you believe the association is real? And if so, why is it not causing a negative effect on bone health? And what do you think is the nature of the association? And what are the implications of this relationship?
Let me address the first three discussion points first, and then we'll come back and talk about the fourth one on implications. First, though, I want to start with addressing some things, some noted limitations of the study that I don't think are relevant to this discussion. For example, it's pointed out that the testosterone amount, the way it was dosed, may be suboptimal for bone mass effects. I would agree with that. There was a early dropout rate of over 60%. While that's not real uncommon in very large, long randomized trials, it's one of the problems we have with those kind of trials. So that's a significant concern. However, these could obscure a decreased risk of fracture, which is what I think we anticipated it showing. It's completely unhelpful to explain an increased risk of fracture on testosterone replacement therapy. Now, let's talk about what I do think is relevant to unraveling the true nature of the association of TRT and musculoskeletal injury. First of all, when you think about the positive effects on bone health that we've already mentioned that have been shown in numerous studies of testosterone, when you consider the fact that studies show that increased muscle mass and performance are strong independent predictors of fracture risk, both of which are improved on testosterone. And then consider, the whole counterintuitive idea that a hormone, from an evolutionary biology standpoint, intended to make us a warrior and hunter, would actually cause us to be more prone to fracture. These are all red flags that point away from interpreting this association as testosterone having some negative effect on bone health. On the other hand, when you look at this cohort, you're talking about cardiovascular patients that are older men and are hypogonadal, which means they have a condition that has a number of effects that are very, very relevant to understanding testosterone's relationship to musculoskeletal health. For example, hypogonadism in men can be associated with decreased motivation and socialization, increased fatigue and apathy, depressed mood, negative outlook, loss of muscle mass, strength, and performance, decreased bone mass, and not counterintuitively, decreased physical activity and exercise, and hence increased risk of sarcopenia and frailty, and I would suggest hence increased risk of musculoskeletal injury. Thirdly, there are effects of testosterone treatment that have significant implications in regard to the relationship of testosterone treatment to risk of fracture and musculoskeletal injury generally. Um, for example, current studies indicate that higher levels of testosterone and testosterone treatment itself are associated with a decrease in things like fatigue and apathy, improvement in mood, sociability, confidence, uh, improvement in joint stiffness and pain, improvement in motivation, including the motivation to exercise, improvement in mass and strength of both muscle and bone, and both of which are associated with a decrease in fracture risk. Studies have also shown an increase in impulsivity and, interestingly, an increase in risk taking.
So, are these effects consistent with your own research observations?
Yes, in our long term research, we certainly noted all the effects just mentioned as far as the effects of hypogonadism on men. In fact, many of our observations preceded their documentation in the literature. Same thing with testosterone treatment as well. But beyond that, very early on, we observed that these effects increased the level and intensity of exercise, and that increase in exercise and risk of exercise and behavior was leading to increased musculoskeletal injury.
So, given all this information, how does that affect our understanding of this relationship between testosterone treatment and an increased fracture risk?
I think if you analyze the studies that we have, this study on fracture, but the other studies that showed testosterone treatment was associated with more musculoskeletal injury, if you analyze it in the context of all this information about the effects of testosterone, that it would seem intuitive that testosterone treatment may have an indirect negative impact on fracture risk by promoting more exercise and the intensity and risk taking of such exercise. Um, on the other hand, had they controlled for these kinds of things, and none of these studies did, none of the studies controlled for these kinds of effects, exercise, level of physical activity, the intensity of it, the risk of it, and general risk taking. Had they done that, I believe it would have eliminated any increased risk of fracture uh, in the studies and or other musculoskeletal injury, and it would confine it all to those factors. In fact, I would suggest it's intuitive that any intervention that we have in medicine, whether it's available now or those that become available through future research, any successful intervention, we're looking for them to increase physical activity and exercise, especially if we do it according to the guidelines of what that should mean, is going to increase the risk of musculoskeletal injury.
When did you first encounter this concern of musculoskeletal injuries in patients that you were treating with SHOT? And can you give case examples?
Sure. It actually started very, very early. You understand when I started work on this in residency over 35 years ago, I hate to admit, uh, no laughter. Um, the truth is, nobody was really involved in this area at all. I could find a few urologists who, out of compassion, would give shots to older men for sexual problems. As the one great physician, a surgeon, and told me, he said, Jeff, let me be honest with you. We had a question in residency at a Q&A, what could you do for sexual problems, ED, whatever, impotence? You give 200 to 400 milligrams IM injection, every month, and see if that works next. He said, that is the sum total of my training. He said, it's atrocious. I'm glad you're interested in this area. I remember asking, do you get labs? He said, I know I should, theoretically, but I have no idea what I would do with them. I don't know when I would do it. We have no training whatsoever in this area. And so the only people really being treated in those days generally, and that's kind of where I started getting some experience and training, was older men, much like in the fracture study. They had a lot of medical problems. Some of them were quite frail. So very early on, we started treating younger men too, but these were the people we treated at first. Um, and we started noticing that they're getting more active, which was great. I mean, we encourage that. There's all kinds of recommendations. We know that depreciating muscle mass is associated with worse outcomes in people as they age, and for quality of life and independence, etc. So, and it was really helpful also, obviously, in helping them succeed and losing weight. So we were excited about that. Often their mates, family were excited about it. However, we very soon started having people report concerns about this, sometimes through phone calls to the staff. Um, One case that I remember early on was a woman who'd been very, very happy with all kinds of changes about sex and everything else, and the fact that he was no longer a lump on the couch and a couch potato. He was getting out and doing more, and much more helpful around the house. But she was yelling at him while she had me on the phone. I'm not sure what she thought I was going to do, but he was up in a tree with a chainsaw, cutting. Now, he'd not been on treatment much, so he's still debilitated, and yet this is what he's doing. And she assured me this was not his usual behavior for years. He just didn't do this. We'd have other cases where we have young men start training like they're training for the Colts, even though the Colts haven't called, okay? And they would often go back to whatever they had stopped when they were in shape and fit and start with that regimen. And they would get all kinds of injuries. Rotator cuff was common, bicep ruptures, for example, though we've had hamstring issues, Achilles ruptures, you name it. A lot of issues with knee injuries, cartilage and ligamentous, both. Um, and this went on and took many forms. Uh, One I call Love on the Kitchen Table. No, I'm sorry. The one I actually would suggest is actually more perhaps meaningful is Love on the Coffee Table. Apparently, they were saying goodbye at the door, and he was feeling so vigorous, he decided to lift her up, whatever, didn't quite make it, and they went back over onto the coffee table, which shattered. Um, I had people out. One case I call the rototiller rodeo, because his wife called me again, called the staff because he hadn't used a rototiller for years. Hadn't even attempted something like that. Again, he's early in treatment, so he's still pretty deconditioned, but he's feeling great, and he's out using a rototiller, and she thinks he's going to kill himself. And frankly, he was not a person, at least at that point in his physical conditioning, should have been even trying to do this. Now, beyond that, there's common sense. So I'm going to describe to you a study that a hypothetical study that I use to convey this to colleagues and patients. Think of you're studying musculoskeletal injury in high schools across the country in two groups that you're going to contrast. One is sedentary gamers, the other happens to be athletes. Now, which group will the study find is having more Higher levels, higher numbers of musculoskeletal injuries. Which group?
Obviously, the athletes.
Yeah. Now, are the athletes having more injuries because they have more unhealthy ligament, cartilage, tendon, muscle, bone?
No, I wouldn't
No,
think so
no. Why are they having it?
because they are doing more high risk activities and they're more physically active.
Absolutely. Seems common sense, doesn't it?
Mm-hmm.
Now it's interesting. I also did a little study of my own when this came out, and I looked at it and analyzed it quickly, and then sent in an editorial about what I thought was going on. I didn't tell anybody at first, and so I would ask the men coming in, and I would tell them, "Wow, there's a study. You may have seen it, and it showed increased fracture in the older men on testosterone, not the hypogonadal men that were on placebo. What do you think of that?" Every single one of them says because they're doing more. They're out there doing more, just like me. Like when I started treat, and so I would suggest some of this is common sense, and it's unfortunate. Again, I think it's an unfortunate consequence of not having clinicians more directly involved routinely in the design of these kinds of studies, and the analysis of the data that comes out of them. But that's why, even from the beginning, not that I didn't think there was a relationship, but I didn't think the relationship between the increased injury had anything to do with a negative effect on those tissues.
So let's talk a little bit more about the implications of testosterone treatment effects. Firstly, how exactly have you modified your approach to the patient? And is there any recommendations or changes that you would make to your colleagues?
It's a great question. Very early realized we've got to make changes. We got to keep people out of trees with chainsaws that are frail, to use an example. But so the other side of it too is that I didn't mention earlier. It wasn't just musculoskeletal issues. We also had more people presenting with angina after we started them, for obvious reasons. So, number one, we really geared up, and we have probably one of the strictest, most comprehensive evaluation processes at the time of initial evaluation before treatment, when it comes to cardiovascular health. Um, to make sure that we're going to have them do things consistent with their health, and that we don't have problems that we're not aware of before we push them hard. Um, when it comes to musculoskeletal health in general, we've integrated into our initial and ongoing education and reminding people about these kind of effects. And we joke about it. We give them funny examples, but and we talk to their families as well because we know we need their feedback
Right.
as well and reinforcement that it's very important to take this seriously. They know we push very hard. We were known as an aesthetics place when we weren't aesthetics per se, simply because we do push people hard in a way that does tend to transform them physically, but we want to do that safely. So uh, we spend a lot of time about not just these effects and how that might increase their risk taking, the effects of what happens now versus what takes longer to happen, and how that should affect how they approach the kind of exercise they're doing, the quantity, the intensity. And that has to also be very much individualized based on whether you're talking about a young, otherwise fairly healthy person or a trained person, even more so, versus an out of shape middle aged person versus a frail older person. And it takes time to do that kind of individualization. Um, and then we monitor them very closely on an ongoing fashion, and that's been successful. There's no question that it can help modify the risk. There is no such thing, I believe, as something that can eliminate it. So why have people exercise and do those things? Well, it's all risk benefit analysis, and we know the tremendous value of exercise. And yes, we want to do it in a way to get those risks where we minimize or get those benefits where we minimize the risk, but you can't eliminate it completely, and that's okay. uh, almost every treatment we use has potential risks. And as long as the benefit outweighs the risk, we believe it's worth pursuing. And that's certainly the case with exercise. And yet, I think, and especially because of our time constraints, the way that we handle it presently in medicine with older patients dramatically increases the risk of musculoskeletal injury. That's really what's been our big take-home point, and we've continued to refine it. We already have a form that you and I created as far as having spouse input on mood issues. We try to also get their input, and we may develop forms to harvest that information too, as far as getting them to give us feedback about their behavior and about what they're doing and is it realistic or not? Are they taking risks they shouldn't? And that sort of thing. So that's the big difference clinically.
So, lastly, as a consultant, how has this understanding impacted your recommendations for study design?
When this started happening years ago, and I was a consultant with a number of companies and, talking about study design stuff. One of the things that I came to emphasize when it came to studies on sex hormone is that when you're looking at effects, whether it's benefits or adverse events in regard to musculoskeletal health, that it was absolutely essential that you control for physical activity and exercise and the intensity and level of risk of those activities. Beyond that, though, also general level of risk taking. As you noted in some of the examples I used of injury, a lot of those are not likely to come up spontaneous as something they're going to report to the physician
Right.
or to someone in a trial that they don't even know. So you're going to have something where that is uh, uh, controlled for in a very, very effective way. Yeah, that's been to me the biggest concern that I've expressed, but it's a significant one because literally, as in this case, it can flip something on its head. That is, it can make an outcome be analyzed in a way that it means something that's actually opposite of reality. Um, Hopefully, as studies go forward, and that's why I wrote the editorial, was to hope to get attention brought to that so that future studies looking at these kinds of things don't make similar mistakes.
So, I know that you have been successful in publishing many papers, but you have not been able to get any of your own research published. Why do you think that is?
It's a question that I've had to grapple with um, over the years because it's been a recurrent problem. And sadly, of the papers I've published, uh, those that had consisted of my original research had much greater significance and import uh, to healthcare, actually. Once I published some papers, I really thought that it was a matter of getting established, especially when you're an outsider and you're a full-time clinician that has an interest in research, which was the case for our researchers years ago. Most of them were clinicians back in the old days, but clinical medicine and academics split years ago, and I think it's a very, very unfortunate thing that happened. But so I thought, I just had to get known, established, and unfortunately, after those some of the original papers were published, when I published one of my original papers over a quarter of a century ago about the connection between low testosterone and prediabetes or metabolic syndrome that we found in a naturalistic setting that I practiced in, um, I literally got a response back in 36 hours, and in those days that meant by fax, and it was obvious that it was not read. And this had happened a number of times, when my father came in, my senior partner, and when I told him about it originally, I could tell from his expression, he was very stoic, but um, that he had his doubts, but he wanted me to do it. And he came in later and asked me how it had gone. And of course, I said, I think you know how it went. And he said, so it didn't go well. I said, no. And he said, what do you think? I said, you obviously know. Why don't you tell me? He said, well, what was different with this paper than your other papers? I said, it was a paper, Dad. I mean, what do you mean? What difference? And well, what did they want? From you? My paper, nothing else, nothing else. Well, there's a cover sheet. So what they want on the cover sheet? My names and my affiliations. I remember him shaking his head, and I said, "No, no, but that can't be now. I mean, I have spoken and taught all over the country, outside the country. I've been on national and prestigious boards as an expert. I've been an expert witness in court. That can't be." I said, and why now? And he said, well, what's different between this paper and the other papers you publish? I'm like, oh, Lord, just tell me. But he wouldn't. I said, well, let's see. I had other authors. Who were they? Full-time academics. Bingo. He said, anything else different? I said, well, in some cases, there were grants that supported what we were doing from the pharmaceutical industry. He said, those boys pay their bills at those journals for advertising. They know they better damn well at least read it before he said, when you can send somebody back the response you got, clearly they're sending you a message. They at least could have waited a little bit or act like they were a little interested. They're making sure you understand that when you're not involved with someone from academics, when there's not support, they'll remind you what they really think of you. And that was really difficult. And what he meant, not me personally, but how often academics as a whole, I want to emphasize, looks at clinicians, people who see patients, and as far as not believing they have any role really in research, and it's frankly had tragic consequences for the profession and for the advancement of medical science. And again, I want to note there's a lot of exceptions. I've had the pleasure of working with some incredible academics that care deeply about patients and want clinicians to be involved because they understand the need of that if they're going to be able to do things and to have research and papers and advance the cause of care for the sake of patient welfare. But unfortunately, this is still an issue. And so when I got this back, I knew that you know obviously things have changed. I'd even sent and asked advice of people who are academics and are of that minority of really noble people, and did their best to give me ideas on how to word things, etc. And every one of them, when I sent back and showed them the responses I got, I won't use some of the explicatives that they expressed in their emails, but made it clear to me that that was exactly what was going on. It's because of who I am, not because of the quality of the information or the importance of the issue that I was addressing or my level of background. I mean, I'm probably, I may be the old man when it comes to being a clinician in sex hormones in men and women. There may be other people that have been involved, not just clinically, but also from a research standpoint for over 35 years in the United States. But back when I got involved, it was a Rodney Dangerfield area of medicine. There was almost nothing going on at all, and we certainly got nothing in medical school. But so that it's been a difficult thing, and it presented to me ethical, moral issues when many of the things that we've studied and looked at and still have never been published that have significant implications for the well-being of patients that could lead to people who are better and smarter than I and in a better position to study them further. They could take those things and advance care in areas. In fact, for example, finally is years and years later, what I was saying that was considered heresy about testosterone and diabetes and metabolic syndrome, that's no longer the case. In fact, it's interesting that some of the people involved in that were individuals that acted like I wasn't making sense when I first brought up the possible connection 30 years ago. But be that as may, the important thing is those things are advancing. But the sad truth of it is they could have advanced much, much faster. This is the same issue we dealt with in obesity. I was a heretic also in saying that it was a medical problem, not a behavioral problem, and that if we would simply study it, we would find the underlying mechanisms, be able to target them, and have effective treatments. At one time I thought I was going to die before that medievalism went away, that was inhibiting that kind of research in medicine. But thank goodness it's here. I'm grateful for that, and I'm excited about it. But there's no question that it should have happened much, much, much sooner.